So, first of all, let me thank you, the church, for the nice presentation and all of you. It is a great privilege for me to start this meeting with you. So, let's go straight to the point. So, this is listed my disclosure. And let's begin with our agenda that we are going to explore, the LH, the concept of LH and FSH deficiency. But first of all, we should unravel the role of FSH and LH during the follicular genesis. So we should understand properly what happened during physiological point of view in order to understand how to tailor our treatment, how to improve the way to treat patients. So from a physiological point of view, we could say that the follicle genesis is mainly orchestrated by at least two great musicians. The first one is well known, is the FSH, because the FSH regulates the follicular growth, and we know that the medication that we prescribe are based on the FSH, but another great musicians is the LH2. So both the LH and FSH are crucial during follicular genesis. Immediately after, during the luteal phase, it appears another important musician, that is the ACG. So it means that the ACG and the LH, from physiological point of view, are two musicians that play two different kinds of music. The first one, the LH, is crucial for follicular genesis and for follicular growth, and the second one is crucial for the sustainment of the pregnancy and for the luteal phase. More in detail, what is the role of LH during follicular genesis? Since the early follicular phase, the LH mainly acts on the theca cells, inducing androgens productions. And we know that androgens are crucial for follicular genesis because estradiol products derive from androgen products. And as well, the LH acts synergistically with FSH in order to increase follicular growth, and also plays a crucial role for paracrine activity that sustains follicular growth. So we can say that in the first part of follicular genesis, the main action of LH is in terms of oocyte quality, because it increases androgen production that represents the fluel, a sort of fluel of follicular genesis. In the second part, the granulosa cells starts to express LH receptor. So it means that the growth of the follicles is sustained by LH2. So the LH is very important since the intermediate follicular phase, because the LH acts mainly on the mechanism involved in oocyte quality and in oocyte growth. So in the first part, mainly LH acts on oocyte quality. In the second part, main acts on the quality. To sustain this, there are some evidence that demonstrate that the LH is capable of effectively completing follicular maturation even without the FSH support. So the LH is able to sustain by itself the growth of the follicle even without any FSH supplementation. So it means that the follicle are sensitive to LH, and LH is very important for follicular growth. From a qualitative point of view, the LH acts increasing the oocyte competence, because it's not only important the quantity of eggs that we achieved during controlled endometrial stimulation, but it is also crucial the oocyte competence, because the oocyte competence is related to the blastocyst rate and is related to the clinical pregnancy rate. So there are a huge amount of evidence that sustain that the LH is able to enhance cytoplasmic activity, thereby increasing oocyte competence and quality. So we have clarified that during follicular genesis, both FSH and LH act together, play together in order to sustain follicular growth in terms of quantity, but also follicular growth in terms of quality. Especially, the quality is mainly related to the effect of LH since the intermediate follicular phase. Now, let's start to the core of this lecture. So, the definition of FSH and LH deficiency. The LH and FSH deficiency is a spectrum of conditions with various etiologies. So there could be different causes that can induce this kind of pattern. There could be functional, so there are specific eating disorders that could be related to gonadotropin deficiency. It could be organic because there are some kind of tumors that could reduce dramatically the production of LH and FSH at the pituitary levels. But also there are conditions that are iatrogenic and are related to the other factor. Maybe there are also some congenital factors that are related with both FSH and LH deficiency. Indeed, there are specific genetic characteristic, genetic pattern, very common, that are called polymorphism, that could be related with reduced FSH or LH function. So definitely FSH and LH deficiency is a complex disorder, but also included some particular kind of patterns that are very important during the management of the patient. An important concept that I would like to stress here with you is that the LH and FSH deficiency could be independent of serum levels of both gonadotropins. What does it mean? It means that we could have a deficiency that it is not related to gonadotropin levels. So the gonadotropin levels are within the normal range, normal values, but as a consequence, we have a reduced action of gonadotropin effect. This is the reason why even the most recent and famous definition of hypo-hypo take also into account the fact that we could have normal serum gonadotropin levels and that the effect could be mainly observed in terms of action instead of only productions. So the LH and FSH deficiency could be independent from serum levels, but another very important aspect that we should understand is that there are some stressful conditions that we usually should do during control and ovarian stimulation that could cause this FSH, this gonadotropin deficiency. And this stressful condition is the controlled ovarian stimulation. Because during controlled ovarian stimulation, what we do, we usually prescribe pituitary suppression regimen because we want to prevent the ovulation rate during controlled ovarian stimulation. But there are specific subgroup of women that may be unable to adapt to this stressful condition. So specifically, particular kind of woman may be not able to counteract the effect related to gonadotropin degenerate analogs that we prescribe during controlled ovarian stimulation. An example of this specific kind of woman, so what are these kind of women? The first example is the woman that presents the hypo-response. So woman in which we have reduced number of eggs considering the antral follicle counts of the ovarian reserve that we have at the beginning of the stimulation. So there are specific kind of women in which we have a discrepancy between what we have at the beginning of the stimulation in terms of antral follicle count and what we achieve at the end of stimulation in terms of oocyte eggs and number of eggs that we achieve it. So these patients usually present specific genetic characteristics, or also this condition could be related to some metabolic disorders. You know that, for instance, women with increased BMI present a sort of resistance to exogenous gonadotrophin and could present this sort of discrepancy and this sort of hyperresponse profile. Another example of women that we usually see, that we usually treat in our IVF clinics, is women with advanced reproductive age. So above 35 years old, we see that the LH function, it seems to be reduced in terms of androgen levels, for instance. And we know that the androgen levels are crucial to sustain follicular genesis because they represent the base to sustain the follicular growth. Without a proper androgen production, we do not have a proper production of follicles that we need in order to sustain our controlled ovarian stimulation. So at least we have two different kinds of patients in which we have a sort of latent LH deficiency. Women that present hyposensitivity to exogenous gonadotropin, a woman with advanced reproductive age. So it helps me to explore what are the possible therapeutic options in order to correct this kind of FSH and LH deficiency. As I told you before, there are two specific subgroups of women: women with advanced reproductive age and women with a hypo-response. This kind of women were included in Poseidon criteria. As you know, Poseidon criteria are essentially based on three elements: the chronological age, ovarian reserve, and number of eggs retrieved. Especially if you see group 1 and 2, we have women with hyperresponse, in which the hyperresponse is more common because the number of eggs retrieved is not consistent on the good ovarian reserve that we have. So we call this patient as unexpected poor prognosis related to the number of eggs that we achieved, because we know that the highest is the number of eggs that I achieve during controlled ovarian stimulation. The highest are the chance to achieve a live birth rate at the end of ovarian stimulation. As I told you, group 1 and group 2 present this hyposensitivity, and there are different metabolic or genetic patterns that could be related to hyposensitivity. For instance, the presence of specific polymorphism, or maybe some metabolic disorders such as obesity or other conditions that could be related to the hypersensitivity. So, from therapeutic point of view, can we increase the ovarian response in this patient by adding LH activity during ovarian stimulation? The answer is yes, because collecting all the studies that was published that included women belonging to Poseidon 1 and 2, so women that present hyposensitivity, we have an increased number of eggs if we had LH during controlled ovarian stimulation instead of recombinant FSH monotherapy. And we have also an effect in terms of quality. Indeed, we have increased clinical pregnancy rate when we co-treat women with both FSH and LH. Why we observed this? This is a paper that we published together in collaboration with a university in the north of Italy, with the group of Professor Baldi, in which we demonstrate that when we supplemented LH in hypersensitivity women, there is an influence in terms of local steroid production that seems to mimic what happened during the physiological production. So it means that when we prescribe LH, we ameliorate the paracrine activity of our follicles. So this could be an explanation that sustain the role of LH in women with hyposensitivity. One of the possible questions is which kind of LH product we should prescribe in this patient? So urinary product, ACG-related product, or LH-related product? According to this randomized control trial, it seems that recombinant formulation works better in terms of live birth rate and in terms of implantation rate. Even in this study that included women with reduced endoviral reserves, it seems that if we use recombinant protocol, we have a higher chance to achieve a live birth rate. We know that live birth rate represents the primary endpoint of our treatment, and reducing cancellation rate. So it seems that if we use pure LH, we act better. And there is a clearly explanation. I'm going to see the molecular pathway, because the ACG and the LH act in a completely different way. They share the same receptor, but while the LH act inducing proliferation and have an anti-apoptotic effect, the ACG is a fantastic musician, but this musician mainly acts to sustain the pregnancy. So it is a fantastic hormone that sustains the pregnancy because it mainly induces steroid synthesis. So this is probably the explanation why the LH, the pure LH formulation works better during folliculogenesis instead of the ACG-related products. Another subgroup of patients that could benefit from the LH supplementation are women with advanced reproductive age. We know that more and more frequent in our clinic, women with advanced reproductive age suffer from poor ovarian prognosis. Indeed, the chronological age is a crucial parameter for Poseidon criteria in order to identify different segments of prognosis. Indeed, if you observe women with hypersensitivity, we have differentiated a young woman from advanced reproductive age women. Even in these patients, so in women with advanced reproductive age, we see a reduced function of LH. So in this patient, we have a reducing factor of LH that could be enhanced by the presence of GnRH analog regimen during controlled ovarian stimulation. So if we assess the LH values, the LH hormonal levels in this woman, they are perfectly normal. But the function of LH is impaired. This is the reason why, this is the rationale behind the prescription of the LH even in women with advanced reproductive age. Now let's see what is the clinical evidence that we observed in this meta-analysis that included all the randomized controlled trials that was published until 2020. We see that only in a specific subgroup of women with advanced reproductive age, so only including a narrow range, we observed an effect. But if we observe the number of eggs, you see that the number of eggs is significantly reduced when we prescribe LH compared with the FSH monotreatment. So the number of eggs are less, but it is not so important because the action of LH is mainly in terms of quality in women with advanced reproductive age, because if we consider implantation rate, the co-treatment FSH LH comparing with the FSH monotreatment lead to significantly amelioration in terms of implantation rate, and the implantation rate reflects the oocyte competence and thereby influence clinical pregnancy rate. But this effect is mainly observed between 35 and 40 years old, so only in a specific range considering the advanced reproductive age woman. But why we observed this? Obviously, we observed this because we know that there is an age-related aneuploid rate that becomes increasingly more relevant in women above 40 years old. So, in other words, the effect of LH is masked by the fact that, unfortunately, the quality of the embryos in women with advanced reproductive age is dramatically poor. is dramatically reduced. So the effect is mainly observed only in women between 35 and 40 years old, in which this effect is not so dramatic, is not so evident. This study that was published some years later, compared with our meta-analysis, perfectly confirmed what we observed in our meta-analysis. So if we see the number of eggs in women with advanced reproductive age co-treated with FSH and LH is reduced. But if we observe the quality, so the clinical pregnancy rate and live birth rate is higher. So it means that the LH in advanced reproductive age does not act on the oocyte quantity, but acts mainly in oocyte terms, so oocyte competence and oocyte quality. Conversely, in women with hyposensitivity, we see a dual effect, both in terms of quantity, because the LH is able to increase the number of eggs, and in terms of quality. So finally, in women with advanced reproductive age, we observe that the effect is mainly in terms of oocyte competence and oocyte quality. I'm going to conclude my presentation just listing the main concept. The first concept is that gonadotrophin deficiency is not necessarily related to gonadotropin serum levels, and that there are specific subgroup of women that are very common in our routinary clinical activity, because even women with hyposensitivity is not so rare to see, that in which we have this sort of gonadotrophin deficiency that could emerge especially during stressful conditions, so especially during controlled ovarian stimulation. So the women that are affected by especially LH deficiency are women that present hyposensitivity to exogenous gonadotropin, and the hyposensitivity could be related to metabolic disorder, could be related to specific genetic characteristics, and the hyperresponders are definitely the women in which we expect a huge amount of oocytes, but at the end we achieve less compared to what we have at the beginning of the simulation. So there is a discrepancy between what we achieve in terms of oocyte quantity and what we have in terms of ovarian reserve and antral follicle count. And also we have women with advanced reproductive age that present this LH deficiency. The message is that while in women with hyposensitivity, the LH could increase both quantity and quality, so could increase the number of sites retrieved and could ameliorate the live birth rate, in women with advanced reproductive age, the effect in terms of quality instead of quantity is mainly observed between 35 and 40 years old, because we have this age-related deficiency in terms of embryo quality. So above 40 years old, the quality of the embryos is too poor. So we have, unfortunately, no magic wand that could restore the quality of the embryos, but the LH could be useful at least between 35 and 40 years old, in which the effect of reduced quality of the embryos, so the age-related effect, is not so dramatic. So let me thank all of you for your attention. I would like to thank my mentor, Professor Alvigi, but all the Poseidon groups, all the Poseidon guys, and it was a great privilege for me to be here with you, and thank you so much for your attention.